Okay. All right, I'm gonna give everyone a couple of seconds here just to file in. Thank you all for coming. Apologies for starting a couple minutes late here. Okay. All right. Great. Well, hello, everyone. Thank you all so much for being here today. Welcome to our side event to kick off the side events here at the 65th CND. My name is Jake Agliata. I'm the Policy and Communications Officer for the International Network of People Who Use Drugs, and it is my pleasure to be chairing this side event for you today, Ending Inequalities for People Who Use Drugs, How the Global AIDS Response Can Transform Drug Policy, and vice versa. So I'd first like to thank all of our co-sponsors along with input, Medicines du Monde, UNAIDS, UNODC HIV/AIDS section, the Netherlands Ministry of Foreign Affairs, and Australia. I'd also like to thank the Robert Carr Fund for Civil Society Networks and the Love Alliance for their support to put on this side event today. And before we go into things and I introduce our first speaker, I just want to go over a couple of housekeeping rules and just things to know. First off, that we are recording this side event today, so everyone is aware, and we will have it available online afterwards. We also have interpretation available in Spanish, French, and Russian. To use interpretation, you can go to the bottom screen on your toolbar, click interpretation, and click the proper channel that you would like to join. And finally, we hope to have a short Q&A section at the end of our side event today, time permitting. And we would please like to ask everyone to add your questions throughout the event using the Q&A function. And when you're asking questions, and feel free to submit them anytime throughout the webinar, and we'll call on them at the end, please just indicate which speaker or which group of speakers you'd like to respond to your question if you have someone in mind. Thank you. So now I want to hand it over to our first speaker, first two speakers rather, Judy Chang, my colleague at the International Network of People Who Use Drugs. She is the executive director, and she'll be giving some opening remarks and introducing our other first speaker. So whenever you're ready, please take it away, Judy.
Thanks, Jake. Just wanted to welcome everybody to this side event, and really glad that everyone can join us. So just wanted to emphasize, input as a global network of people who use drugs. We've always been very tied to the HIV movement, and we've always had this common advocacy where we've been pushing for the world and drug policy itself to recognize that health inequalities, which manifest for people who use drugs in the severe lack of access to rights-based and evidence-based services, such as harm reduction, is at the very heart of what is wrong. But we know that these health inequalities aren't natural phenomena. It is the drug policies and the current global war on drugs that really pushes people to the very margins. It's criminalization, stigma and discrimination that is driving poverty, violence, harassment, incarceration, invisibilization, and the lack of funding for life-saving services for people who use drugs. So the global HIV response, with its recent 10-10-10 societal enabler targets and the 80-60-30 community-led responses targets, need to really be brought to bear on drug policy. And of course, given the context that we in the situation, we are in today and witnessing, nowhere is this inequality more prominent than we see in crisis and emergency situations. Input stands in full solidarity with people who use drugs in Ukraine, whose unique challenges and voice are at risk of being forgotten. So I'm very pleased today, and we're very fortunate to have a guest speaker, Galina Kornienko. She's the project coordinator of the Ukrainian Network of Women Who Use Drugs, who will be speaking on behalf of the community of people who use drugs in Ukraine. Thank you so much for being here, Galina.
Okay. Hello. I have my helper, my translator, and I will speak Ukrainian, and she will translate it. Okay, dear friends and partners, I have the honor to speak today on behalf of two national networks of people who use drugs in Ukraine is Ukrainian Network People who use drugs, Volna, and Ukrainian Network Women who use drugs, Unvud. The leaders of these networks, Tatiana Lebed and Oleg Dymoretsky, are currently in Ukraine, and I cannot say that they are safe now. But I will try to convey the joint position of the two organizations. Далі українською. Будь-яка криза завжди показує найвразливіші місця будь-якої системи. Чи може бути криза страшніша, ніж війна і стан невизначеності, який виникає при цьому?
Any crisis always shows the most vulnerable spots of any system. Could the crisis be worse than a war and the state of uncertainty that arises with it?
Багато років в Україні будували сталу систему профілактики та лікування ВІЛ. Багато років чоловіки та жінки спільноти людей, які вживають наркотики, працювали над тим, щоб доступ до послуг був рівним, щоб зменшувати рівень стигми та дискримінації.
For many years, Ukraine has been building a sustainable system of HIV prevention and treatment. For many years, men and women from the community of people using drugs have been working to ensure equal access to services, to reduce stigma and discrimination.
Але ця найстрашніша для нас криза, ця війна, ця підступна агресія проти мирних мешканців, яку розв'язала Росія проти України, це показало, що ми робили недостатньо.
But this horrible crisis, this war that Russia has waged against Ukraine, this insidious aggression against civilians, has shown that we have not done enough.
Ми разом працювали над впливом на державні політики. Ми мобілізували та посилювали спільноту. Ми працювали над розробкою гендерно-чутливих послуг. Якби не війна, ми б зараз розповідали про нашу важку, але послідовну працю з адвокації.
We worked together to influence public policies. We mobilized and strengthened the community. We worked on the development of gender-sensitive services. If it weren't for the war, we would now be talking about our hard but consistent advocacy work.
Але криміналізація наркоспоживачів все зводила на нівець. Саме криміналізація наразі є важливою перепоною для безпечного переміщення людей з небезпечних регіонів. Бо люди побоюються, що не зможуть отримувати послуги замісної терапії або АРТ в місцях, куди пропонується евакуація.
But the criminalization of people using drugs nullified everything. Criminalization is currently one of the biggest obstacles to the safe movement of people from dangerous areas, as people fear that they will not be able to receive OST or RT services at places they might be evacuated to.
На окупованих територіях отримання лікування припиняється. Альтернативні кабінети видачі замісної терапії, так зване платне ЗПТ, закрилися. В багатьох аптеках неможливо купити препарати за рецептами, бо нарушена логістика і препарати не доставляють, або через те, що аптеки зачиняються і просто не надають послуги.
In the occupied territories, medical treatment is suspended. Alternative medical offices that provided OSTs, the so-called paid OST, are closed. In many pharmacies, it is impossible to buy prescription drugs because the logistics were destroyed and drugs are not delivered, or because pharmacies are closed and simply do not provide services.
Більше того, ми маємо посилення рівня стигми та дискримінації щодо людей, які вживають наркотики. Стигма та дискримінація під час коронавірусної кризи були першим сигналом про те, що державні системи охорони здоров'я та соціальної допомоги не працюють під час кризи. І про те, що ми робимо недостатньо для того, щоб захистити людей від позорного сортування на нормальних та ненормальних.
Moreover, we have observed the growth of stigma and discrimination against people who use drugs. Stigma and discrimination during the coronavirus crisis were the first signs that public health and social care systems do not work during the crisis, and that we were not doing enough to protect people from the disgraceful sorting into categories of normal and not normal people.
Ми закликаємо всіх, хто працює над глобальною відповіддю на ВІЛ, звернути увагу на те, що без потужних рішень щодо декриміналізації наркоспоживачів люди будуть постійно в ситуації небезпеки, а кожна криза вбиватиме їх фізично через неможливість дістатися до медичної допомоги, через те, що соціальні послуги надаватимуться їм в останній момент лише через їх діагноз.
We urge everyone working on the global HIV response to know that without strong solutions to decriminalize people using drugs, people will be in constant danger, and every crisis will kill them physically because of the inability to access medical care, because social services will be provided to them at the last minute only because of their diagnosis.
And if we say that human rights are valued to us, let's show it by action, because appeals do not work now. Thank you.
Wonderful. Thank you. Thank you so much for being here today, Galina, and really appreciate your perspective being here, and really appreciate you taking the time to come and share your experience and your perspective from the ground. Very, very powerful, and really appreciate you being here and all the work that you're doing. So we would like to move on to our next speaker now, who will be Suki Beavers. Suki is the Director of Gender Equality, Human Rights, and Community Engagement at UN AIDS, and will be giving us an overview of the new global AIDS strategy, which was passed last year, and specifically the 10-10-10 and 80-60-30 targets, which our other speakers will be touching on throughout our side event today. So I'm going to hand it over to you, Suki, and start sharing your slides in just a moment. So whenever you are ready, go ahead.
Thanks very much. Today, on the first day of the 65th session of the UN Commission on Narcotic Drugs, we have to face the fact that millions of people who use drugs are left behind in the global AIDS response. While we've seen a decline of new HIV infections among people of all ages worldwide by 23% between 2010 and 2019, there's no evidence of a change in global incidence among people who inject drugs. And in some regions, incidence has increased. In 2020, 9% of all new HIV infections were among people who inject drugs. The new global AIDS strategy uses an inequalities lens to close the gaps preventing progress to end AIDS, and sets out bold targets and policies to be reached by 2025. Low access to HIV services among people who inject drugs is one of the largest gaps in the HIV response, and criminalization of drug use or possession for personal use leads to widespread violations of human rights and sets additional barriers to services. So I'd like to draw your attention to several targets of the new global AIDS strategy that are important for our discussion today. First, let me mention access to harm reduction programs and opioid substitution treatment, because we are so far behind in reaching those targets. As you'll see in the left-hand column, 90% of people who inject drugs have access to comprehensive harm reduction services is the first of those targets. And the second is 50% of people who inject drugs and are opioid dependent should be covered with opioid substitution therapy. Then in the middle section, the middle column, we see the decriminalization targets. And these include, by 2025, less than 10% of countries criminalize possession of small amounts of drugs. The second target is that the UN Common Position on Drug Policy that was released more than 3 years ago reflected a UN system agreement on the need to decriminalize drug use, and committed to taking actions to promote it. In 2019, 111 out of 134 countries reported they criminalized drug use or possession for personal use. Only 23 countries allowed for legal possession of a certain amount of drugs, and the progress on decriminalization is very slow. And in the last column, you'll see on the right-hand side, you'll see the targets related to community-led response. UNAIDS has been committed to promoting and supporting community-led responses for a long time. This new strategy sets an 80% target for community-led service delivery for HIV prevention programs, a 60% target for community-led advocacy, and a 30% target for community-led treatment services. By community-led, we mean peer-led. So key population prevention programs should be key population-led because we know that this is what works. Organizations of people who use drugs and other civil society organizations are instrumental in the delivery of harm reduction services, service planning and monitoring, as well as advocacy and accountability. And people who use drugs also need to be recognized as experts and partners in drug policy and HIV response, and empowered to lead and make decisions in all areas that affect their lives. Now, these targets are interrelated. We can't reach harm reduction access targets if drug use is criminalized. We can't reach decriminalization targets if communities are not leading the drug policy advocacy efforts and get funded adequately to do so. And at the same time, access to quality harm reduction programs can be achieved only if communities plan, deliver, and monitor the quality of harm reduction programs. Next slide, please. Here, I'd like to draw your attention to a platform that we jointly use to coordinate and intensify the efforts towards these targets. And this is the Global Partnership to Eliminate HIV-Related Stigma and Discrimination. This global partnership was formed in 2017 to harness the combined power of governments, civil society, bilateral and multilateral donors, academia, and the United Nations to eliminate HIV-related stigma and discrimination and to inspire countries to take action to remove critical barriers to HIV services. Co-led by UNAIDS, UNDP, UN Women, GMB+, and the Global Fund for HIV, Tuberculosis, and Malaria, and the PCB NGO delegation, the global partnership has increased coordinated technical assistance and leveraged synergies of action to support country efforts and end stigma and discrimination across 6 settings, which are healthcare, justice, education, workplace, humanitarian, and community. And as of February of this year, 29 countries have joined the global partnership, as you can see on this map. Next slide, please. So as you'll see on the left-hand column of this slide, the country commitments that are made, and you'll see the list there that is really important. And on the right-hand side, you see the various tools and resources that we've developed and used to support countries in meeting these commitments. And we hope that with these instruments, with the increasing support of the UN system to human rights and health-based drug policy, to decriminalization, and to the elimination of drug-related stigma, with these, we hope that the community of people who use drugs will start to see positive changes and a positive impact on their lives. Finally, on behalf of UNAIDS, I want to express support to people who use drugs and their families that are struggling in the military attacks against Ukraine, which has caused severe health and humanitarian crises. And we know that people who use drugs are among those who face life-threatening consequences of this attack. They need uninterrupted access to methadone, naloxone, HIV treatment, and syringes both in Ukraine and in neighbor countries, which opened their doors to Ukrainian refugees. UNAIDS calls on all partners to work to restore access to harm reduction for people who use drugs and other essential services for people living with and affected by HIV in Ukraine as part of an integrated humanitarian response. Thank you.
Wonderful. Thank you so much, Suki, for that fantastic overview and insight into the targets and also just the general comments around the global AIDS strategy and moving forward and what needs to be done on the country level in order to make these targets happen. So I want to turn now to our next speaker, who will be my colleague from the International Network of People Who Use Drugs, Aditya Taslam. Aditya is an advocacy officer at Input, and he will be discussing the advocacy by people who use drugs during the development of both the global AIDS strategy and the 2021 political declaration, and why the targets are important to the community and how the community is using them moving forward. So Aditya, whenever you're ready, please take it over.
Thank you, Jake. So hi, everyone. And I also wanted to just extend my appreciation to Alina for sharing your stories and also to be with us here today. So it is actually for the first time in the history of the global politics of HIV, the world has recognized and acknowledged and agreed on the role of societal enablers, including targets and commitments to decriminalize people who use drugs and the possession of drugs. And the process leading to this adoption of the Global AIDS Strategy and Political Declaration came a long way through different processes. A 3-year target setting exercise started in 2018, in which input and other global key population networks and other community experts were also part of it, which led to the set of the 10-10-10, the 80-60-30, and also increase in harm reduction targets. Global key population networks and other community experts were also brought together to establish definitions of key population and community-led network and organizations, as well as key population and community-led responses, which are now used in the Global AIDS Strategy, as well as we are advocating the Global Fund and PEPFAR to adopt and use the same definitions, and also to demand for no more lip service on the long-promised funding for key population. Additionally, we also conducted a global consultation involving people who use drugs around the world, which later was submitted to the Global AIDS Strategy Development Team. Input was also a member of the multi-stakeholder task force co-convened by Aid Funds and GNP+, and ensuring the voices of people who use drugs were included in statements and position, as well as in lobbying member states during the negotiation of the 2021 political declaration. And this, however, has not been without any pushback. It has been very clear that there were conflicting views among the UN member states on equality and human rights, and in the inclusion of key populations, particularly people who use drugs. And it was also for the first time in the history of UN high-level meetings, a resolution was adopted by voting at the request of the Russian Federation. This display further raises the alarm for the community of people who use drugs around the world on systematic efforts to push back against our community, particularly on issues related to human rights, harm reduction, and law reform, which ultimately undermine the global efforts to end AIDS by 2030. As a way forward, we realize translating these targets and commitments into actions remain a major challenge. Without a collective movement in advocacy to push the government and other international partners for their accountability in achieving these targets, everything will stay and remain on paper. Worldwide, only 6 countries have decriminalized drug use and possession. Although more countries are claiming to shift towards decriminalization, the so-called law reforms have only shifted towards administrative laws and penalties that continue to mandate coercion and punitive practices, targeting at highly marginalized people who use drugs, who are homeless, and or spend time in public spaces as they are more visible to police. These include the use of high fines, removal of child custody, compulsory rehabilitation centers, to say the least. Services for people who use drugs, including harm reduction, social protection, and other social services continue to stigmatize and disempower people who use drugs, justified by pathologization of drug use, seeing a person who uses drugs as someone who lacks the ability to make decisions for their lives, and that services are often not designed to the diverse needs of people, women, and young people who use drugs, by affirming abstinence as the only indicator of success. Currently, funding for key population programs remain extremely low at only 2%. To achieve the global targets and commitments, resources must be directed to key population. We'll also require governments and other international partners to stop with tokenism, and that programs for people who use drugs must be designed, implemented, and monitored by, with, and for people who use drugs. Input is providing technical assistance to build the capacity of people who use drugs, improve our knowledge, develop our advocacy skills, and empower us through drug user-led responses and advocacy to monitor progress of the 10-10-10 and the 80-60-30 targets, as well as to hold the government and other international partners accountable. Input has also published community-friendly technical briefs on the Global AIDS Strategy and Political Declaration, translating them into actions in language that is relevant to community at grassroots level. This will empower drug user-led networks to play a central role in efforts to achieve the 10-10-10 and 80-60-30 targets by advocating for policy change, take action to reduce violence, stigma, and discrimination, monitor and respond to human rights violation, and promote community solidarity and resilience. In the context of growing political conservatism, anti-rights political agenda, and systematic efforts to exclude key population, it is time to unite our forces and to reclaim our rights. We call for the government, UN agencies, and other development partners, as well as donors, to recognize people who use drugs as invaluable resources that possess unique knowledge, skills, and perspectives that are fundamental for shaping better policies and programs designed to meet the diverse needs of people, women, and young people who use drugs. Today, we call for full protection of rights and solidarity to people who use drugs living in hostile environment, where people who use drugs continue to receive inhumane treatment, such as in Afghanistan, and to people who use drugs in any parts of the world whose voices continue to be silenced and whose rights remain violated. Today, we stand in solidarity with our brothers and sisters living in conflict environments such as in Ukraine. We stand with Ukraine. Thank you.
Wonderful. Thank you so much, Aditya. Very powerful comments on what the community, the need for community response and what that community response is looking like. So thank you very much for being here and sharing. So I want to introduce our next speaker now. Before I do, just a quick reminder to everyone that you can use the Q&A function to submit questions for our panelists, which will be addressed at the end of the side event if time is available to do so. So please keep sending us questions. I'll see if we have one in there right now. So our next speaker will be Fariba Soltani. Fariba is the chief of the UN Office on Drugs and Crime, HIV and AIDS section. And she'll be speaking to why the 10-10-10 and 80-60-30 targets are important to drug policy, how they can be used, and how stakeholders can work in partnership with people who use drugs to achieve these targets. So Fariba, whenever you are ready, you may go ahead.
Thank you, Jake. I am ready. I can't put my video on. I don't know, for whatever reason it's been stopped, but I can just
We'll work on that.
continue with the presentation. Oh, there we go. Thank you very much, Jake. Thank you to Input for putting this session together, and thank you to the previous speakers for setting the grounds for my presentation as well, which is in line with what my colleagues Suki and Aditya have already mentioned about the global AIDS strategy, the new targets, the ambitious targets that we've set ourselves, and how the new global AIDS strategy can influence the drug policies around the world. So I think Irina was putting up my presentation. Irina, can you do that, or can I share the screen? I don't know what's happening.
I'm sharing the screen. Please let me know if you see it.
I can't see the presentation.
We do not see it, Irina. I'm sorry.
Oh, there it is.
Okay. Oh, there it is. Okay, thank you. So first, I would like to actually thank Galina for joining us in this session and the bravery and what they are actually, how they are suffering in Ukraine, that we stand in solidarity with you, of course, and also with our colleagues and people who use drugs in Afghanistan, as Aditya just mentioned. Our colleagues are working very hard and are based in the countries and trying to provide whatever support that we can provide from our side to ensure that services are continuing for people who use drugs and also for people in prisons as much as we can. So I would like to thank our Galina for joining, and stand in solidarity with what you're doing, and our colleagues stand ready to provide support. So in this slide, I just wanted to just give a very small overview and say that 65% of all new infections globally are among people, among key population. And people who inject drugs are 35 times greater at risk of acquiring HIV than people who do not inject drugs. HIV prevalence among people in prisons is 4.3%. Of that, such that people in prisons are 6 times more likely to be living with HIV as compared to adults in the general population. Next slide, please. And now we have the Global AIDS strategy. We also have the UNODC strategy, and we are working together to make the 2 strategies work in synergy. And so Suki mentioned the Global AIDS strategy and the very ambitious targets that have been set up through the Global AIDS strategy. And within UNODC strategy, we are also to support member states to scale up HIV prevention, treatment, and care, focusing on people who use drugs and people in prisons and other closed settings, and address the related human rights, gender considerations, especially among vulnerable population. Next slide, please. I'm not going to go into these slides because Suki already has gone into in details about the targets that were set. So, and as for the sake of time, so other presenters can also talk about their issues. And so Suki mentioned that we have the 10-10-10 targets, and also the 95, 95, and 90 targets for the Global AIDS strategy. Next slide, please. And we also have the targets for community-led interventions. Again, these were provided in detail by Suki, so I'm not going to go into details for this. Next slide, please. And I mentioned about what we are, what our aims are within the UNODC strategy. So next slide, please. These were not mentioned, actually. These were from the World AIDS Day report, and very important slides showing the barriers to the 10-10-10 targets, that people who use drugs and people in prisons are not involved in developing national policies and guidelines or strategies relating to their health, even when you compare their situation to other key populations. And there is also disparity among between what the national authorities, the data provided by the national authorities, and what is provided by the civil society on the key populations' participation, as you can see in this slide, in the part in the graphs right in the middle. And also in the prisons, the situation is even worse. Next slide, please. And this shows the legal environment. And you can see that the comprehensive data on national drug policies remains scarce. Existing data that shows that many countries continue to uphold discriminatory and punitive drug laws, and criminalization of drug possession and use, and of HIV exposure, non-disclosure, and transmission have been shown to block HIV services and service access and increase HIV risks. So next slide, please. So what do we, and of course we have the, what do we do? What do we have in place to overcome these barriers? We have seen growing political commitment actually on on implementation of the 2016 UN United Nations General Assembly document, the 2019 Ministerial Declaration, and of course the Global AIDS Strategy, and we have now the high-level political declaration on HIV and 2021. So as a result of this, all these documents, we have seen a growing political commitment. In Africa, there is more interest in implementation of harm reduction programs. In Kenya and in Nigeria, we have very strong programs that are going forward. Together with the Global Fund, we are coordinating webinars on harm reduction, and the first one actually was implemented in Mozambique last week, and we have others who are following up in Zambia, Tanzania, and South Africa. And this shows the commitment of countries to really see how they can do things differently in order to ensure that services, harm reduction services, are expanded in their countries. Another good results that we have come up with after many, many years of intense advocacy is the approval of implementation of opioid agonist treatment in Egypt, whereby we are starting the program, and this is really a very big achievement after many, many years of advocacy, and this is thanks to all our efforts together with our partners. And in many countries, for example, in Vietnam, we have seen the take-home OAT was approved in 2020 and is expanded in 2021. So there is a lot of positive and good implementation and commitment is also happening around the world. So next slide, please. Another area that we are very strongly working on is the bringing on board of the law enforcement partners. This is very important, as we have mentioned, and it was mentioned in our consultation, which took place last week by many of our partners, that we need to make sure all the stakeholders are around the table when we are talking about HIV and what needs to be done in the different countries. We have been working with our law enforcement partners to remove legal barriers, discriminatory laws, policies, and practices that hinder access to HIV services for people who use drugs and people in prisons. And we want to strengthen partnerships between health, criminal justice, law enforcement, prison administration, and civil society. And on this note, actually, we have, we have tools that we were developed since 2014, and we have been providing training to law enforcement sector, but not only. And through the past few years, we have managed to train over 5,000 law enforcement officials, over 1,500 civil society partners. And the important thing is to have these trainings to bring the law enforcement and the civil society partners together to really hear about the barriers and to listen and see how they can become a part of the response and not become a barrier to the response. And we have been working and reaching over 400 parliamentarians in our high priority countries. And we hope that we can expand this even further. And we have also this tool, the HIV tools for police, already incorporated in police academies in Belarus, Kazakhstan, Kyrgyzstan, Moldova, Myanmar, Thailand, Vietnam, Ukraine, and Uzbekistan. And this is what we are promoting, and we hope that we expand this, because this is how it becomes really regularized, and community-based and public health-based policing becomes a part of the program of the law enforcement in the different countries. Next slide, please. So in prisons, we are also doing a lot of work, as many of you are aware, because you're partnering with us. We are partnering with, we are promoting non-custodial alternatives to incarceration for minor non-violent offenses and alternatives to punishment or conviction for drug use, as emphasized in the outcome document. We are partnering with many other partners on recommending reducing incarceration of people who use drugs, to end the use of compulsory detention for the purpose of drug dependence treatment. This is especially focused in Southeast Asia. And we are advocating a comprehensive package of 15 key interventions, which has been updated for prisons and other closed settings. And I have many examples of the work that we are doing. One of the very active regions where we are working in prisons is in the Middle East and North Africa, in Sub-Saharan Africa, and we have been working on OSD, for example, in prisons, as in the case in Mombasa in Kenya. Next slide, please. And one topic that was mentioned by the previous speakers is the UN Common Position on Drugs. We also have the UN System Common Position on Incarceration. UNODC is the lead of the task team, and we have been working very closely with UN country teams at country level to make sure they can use the UN Common Position for advancing their drug policies at country level. And also the UN System Common Position, which is again led by UNODC together with OHCHR and DPO, where we are working to reduce incarceration in the different countries. Next slide, please. This is a slide that actually, again, was taken from the UNAIDS World AIDS Day report, and it shows that how invisible our population remains. And the need for having better data, this also came out of our consultation, that we need to have better data and better evidence for countries to do evidence-based drug policy based on what information they have. And the fact that the stigmatization and the criminalization in many countries actually they stop the evidence from being represented in the different studies. This also was discussed in our consultation, and the situation that we really need to have better evidence in order to have better drug policy at country level. So this is just another slide I wanted to highlight and look at. So next slide, please. And of course, we are fully supporting the scale up of community-led service delivery for people who use drugs, integration of people who use drugs, community-led HIV responses into all national HIV responses. And as was mentioned by Adita, the adequate resource allocation for sustainable community-led responses. We are very proud of the work that we are doing together with our partners. We've had we enjoy our CSO group. We had a meeting last week. We have a joint work plan, and really, really appreciate the work of our community involvement in this group, in everything that we do, from the joint planning, monitoring, and evaluation of our work. And also, next slide, please. I think this has already been mentioned. Yeah, we facilitate inclusion of community-led organization in the national-led responses. And we also had a grants program last year to facilitate the activities of community-led organizations in the sectors of drug use, HIV, prisons and HIV and law enforcement. So this, next slide, please. These are all the community-based organizations that we supported last year. I want to thank them for all the hard work that they had done to implement the program. And I would like to again thank Input for all their support, all what they're doing, and say that we are here to join our hands and hopefully work together for better results and implementation of the 10-10-10 targets. Thank you, Jake, and I stop here. Thank you very much.
Thank you so much, Fariba, for being here. It's so great to hear from people at the UN agencies who are working or working in partnership with community and people who use drugs, and really appreciate you being here and your detailed presentation and comments. So I wanted to go ahead and move us along to our next speaker. We have 2 remaining. So I hope people can stick around to hear our final 2 speakers and maybe get to some questions. Next, we've heard from the community, we've heard from people from UN agencies, and now we want to hear from a representative from a member state, the Netherlands. So I'd like to introduce Pascal Grotenhuis, who is the Director of Social Development and the Ambassador for Women's Rights and Gender Equality for the Netherlands. So Pascal, whenever you're ready, please go ahead and start.
Thank you very much, Jake. I think my video is locked.
If I can change that for you.
Can you try again, please, Pascal?
Yes. Yeah, there we are. Lovely. Very good afternoon, friends and colleagues. Let me start by thanking Gulina for your brave story, and also echoing Suki, Adita, and Fariba on their very wise and heartfelt words just now on the people who are struggling and suffering so much in Ukraine. I just want to echo that we stand in solidarity with you, and our minds and hearts are with you as well. I'm delighted to speak at this side event at the 65th session of the CND on a topic which is close to my heart and close to the heart of the previous speakers as well: how to shape policies and programs that make sense to the people we serve. Whether in the wider HIV/AIDS response or in drug policy, people should be at the center. The system should work for the people and not the other way around. And this is what makes the side event so relevant: ending inequalities for people who use drugs, how the global HIV response can transform drug policy, and vice versa. My main message today is just that we can't end the HIV/AIDS epidemic or solve the world drug problem without understanding the needs and the behaviors of the people. I remember when I was ambassador for the Netherlands to Mozambique, I remember a teenage girl, Paula, who was living with HIV, but she did not dare to go to the clinic out of fear of being yelled at by the health worker or to be seen by family members on the way to the clinic. The fear of stigmatization and discrimination is real and has real consequences. Last year was an important year for the international community to recommit and take action to empower girls like Paula. The need to lift barriers that prevent people to seek prevention, testing, and treatment was highlighted last June during the high-level meeting on HIV/AIDS as a key step towards ending AIDS as a public health threat by 2030. The political declaration on HIV/AIDS that already was mentioned by the previous speakers that came out of that high-level meeting, as well as the new global AIDS strategy, now includes specific targets to lifting these barriers, the so-called 10-10-10 targets that Suki already mentioned. Less than 10% of the countries have punitive legal and policy environments that lead to the denial or limitation of access to services. Less than 10% of people living with HIV and key populations experience stigma and discrimination. Less than 10% of women, girls, people living with HIV and key populations experience gender-based inequalities and all forms of gender-based violence. And even though less of 10% is of course a very good target, I would hope that we can go to 0%. So if you ask me what drug policy makers can learn from the HIV response, it's precisely this: removing legal and structural barriers especially laws that criminalize key populations. People who use drugs need care. They don't need blame. Understanding their needs instead of judging their behaviors. Dignity and rights of each human being should be the main principle behind all of our policies and all of our actions. This urgent calling to set aside stigmatization and punitive attitude towards people who use drugs was also stressed last month during the African Drug Policy Day. And allow me to echo some important messaging from a partner, the South African Network of People who Use Drugs, SANPUD. Their messaging was clear. When providing HIV services to people who use drugs, there should be no expectation of abstinence and no attempts to coerce people into ineffective and inappropriate treatments. Although people who use drugs suffer health issues, this is largely due to the consequences of prohibition. And that is why the Netherlands HIV/AIDS programming is centered around community-led responses. The partnerships with Love Alliance and the Robert Carr Fund, who are also present here today, are an example of that. Let me clarify, community first means putting the people before the disease, HIV and AIDS, and meaning putting the people before the problem, drugs. The intention of Dutch investment in community networks is to enhance them, to advocate for their own rights and their own health. Let me conclude by underscoring the strong commitment of the Netherlands to put our money where our mouth is. We will invest in lifting the barriers and in community-led response. I'm looking forward to the rest of the discussions with you today and to work closely with you and all the previous speakers to reach these targets. Thank you.
Thank you so much, Pascal. It's great to hear from someone from a member state being here and talking about the importance of putting people first and working alongside the community. Very nice to have you here. I know we're running a bit close on time here for folks, so I just wanted to go ahead and review what we have coming up next. We have one more speaker who I'm going to introduce shortly, and then we have a short intervention from our other member state co-sponsor, Australia. Because it doesn't seem like we'll have time for an in-depth Q&A, I want to encourage people to continue asking questions in the Q&A function, which we can answer in real time if enough space to do so. So please go ahead and submit questions there, or please feel free to keep following this discussion along on social media, hashtag CND65. We'll also be sharing this and posting throughout the week as well and talking more about this. And I'll share links to similar side events discussing this topic, which we will be co-sponsoring on at the end of this. So let me go ahead and introduce our one of our two final speakers, Anidi Akpan. Anidi is the Executive Director of Drug Harm Reduction Advocacy Network in Nigeria. He is a member of the community, and he is going to be presenting on just giving a sense of what the situation is on the ground for people who use drugs in Nigeria, and how the targets address issues they face, such as stigma, discrimination, criminalization, and lack of funding. So Anidi, whenever you are ready, please go ahead and take it away.
Okay, thank you very much. Thank you. I hope we can all hear me.
We can, thank you.
Okay, so we'll be talking about the role of discrimination, stigma, discrimination, criminalization of people who use drugs, and achievements of the 10-10 targets. It's quite an ambitious target, and looking at the time frame for achievement of those targets, which is 2025, and also looking at the situation on ground across sub-Saharan Africa, including Nigeria. Next slide. So basically a rundown of what we have on ground so that we understand how to go about achieving this. From the drug use survey in 2018, we have approximately 14.5 million people who use drugs, and 80,000 of them are injecting drugs. We have a prevalence of 10.9 as at 2020, as compared to 3.4 HIV prevalence in 2014. So it means there's been a huge increase in new infections. The policy, the drug policy has not changed. And in fact, what has changed has been towards the negative side. There's been attempts at legislation to increase punishment for people who use drugs and possession of drug use equipment. The attitude generally is still discriminatory. There's still so much stigma, and the discrimination is widening to proposals by the drug law agency to test people for drug use before giving employment or marriages or holding political offices. Next slide. So what is the prevalent issues here in the drug policy environment? We have mainly stigma from both the government and from the public, and even from healthcare workers. Discrimination, same, applies across board. Criminalization is embedded in the Law Enforcement Act, Drug Law Enforcement Act, and there's exclusion of people who use drugs, maybe as an outfall of the criminalization of people who use drugs, because right from the inception of the CCM in Nigeria, we've not had a representative from the community of people who use drugs. Next slide. So while this just came up yesterday, there's the belief that the law enforcement agency, the drug law enforcement agency here does not prosecute or people who are in possession of drugs for personal use. But this came up, and this is scary. Someone was arrested for being in possession of 0.04 kg. That's about 40 grams of cannabis for personal use. And that's the charge sheet. It shows this real situation across sub-Saharan Africa, different from what we might hear, what is being pronounced by government officials and different representatives of different states in Africa about the issue of drug possession and how it is being treated in the countries. Next slide. Okay, so we look at the real effect. What is the effect of all of this stigma, discrimination, criminalization on interventions for people who inject drugs? First, we are taking this from the 2018 key population size estimates, the findings. So far, from the size estimates, as at when there was availability of service, for people who use drugs, the highest reach was 30% for condoms, 25% for lubricants, 30% for HIV testing, and only 5% had access to needle replacement services. But it's also pertinent to note that 6 months prior to this key population size estimate, these services, STI, HIV, and needle replacement services, including condom, lubricants, and HIV testing services, was not available because of heavy dependence on donor funding. And so when donor funding dries up or there's a lag, in a kickoff of a new program, the space between the program ending and the startup of a new program, there is usually no availability of HIV prevention material and HIV services. And sometimes including even the drugs, stock out. There's experience of stock out of drugs, ARVs, for people who use drugs. And so looking at this side by side with the 2025 targets, it will be it will be difficult to achieve it for sub-Saharan Africa. Next slide. So what's the effect of stigma, discrimination, criminalization, and all of this? There's usually a loss of self-stigma, loss of self-esteem, lack of desire to access HIV services, because people don't want, maybe people have had the experience of being discriminated against at service centers, and so there's no willingness to access service. There's increased risk of HIV due to incarceration. We understand that the prison conditions here and the cell conditions here are not the very best, and a lot of things happen there, including people in cells and prisons still having access to drugs for injection. There's a lack of government funding of services because government is already criminalizing people who inject drugs. Lack of people who inject drugs-friendly services at public health facilities, and dependence on donor-funded one-stop shops, which of course we know is not sustainable. There's resistance to rollout of evidence-based harm reduction services, like what was experienced in Nigeria during the pilot inland syringe program. The program was supposed to be a one-year program, but due to resistance to its rollout, it started late and it was a 6 months program. Inadequate geographic reach of donor-funded interventions, because most of the programs are funded by donors. The services are given at specific locations, so there's no spread to public health facilities. There's no spread to a tertiary, secondary, and primary health care facilities that are funded by government. And so the geographic reach is limited. There's lack of evidence-based and qualitative data to inform programming because, of course, we have people who inject drugs or use drugs are criminalized already. So it's really difficult to put data forward without having to harm the people which you're intervening for. Lack of community structures for community-based HIV prevention program because of course, criminalization. Lack of representation on international, national, and local decision-making bodies, like example of the national CCM in Nigeria. Next slide. So how do we look at this and address these issues so as to achieve the 10-10 targets? We need to address the tripartite barriers of stigma, discrimination, and criminalization by individuals and states to enhance investments in drug user programming. Of course, we understand that even donor funds will need government support for the program before it can be funded in a particular country. As far as we still keep having stigma, discrimination, and criminalization, it will be difficult to attract investment to drug user programs. Need to develop and strengthen collectives of people who use drugs to provide and document community-based services for peers. And this would be the responsibility of both the government and donors. Strengthening collectives of people who use drugs to be able to provide services for their peers. We need to include people who use drugs and inject drugs in planning, implementation, and monitoring of HIV services at all levels. Of course, we understand that, you know, a community of people will be experts in solving the problems that concerns them. And as far as they are not part of the solution, then it will be difficult for the problem to be solved without their involvement. We need to expand community-led services for people who use and inject drugs to uncover geographic space. Example is Nigeria. Programs for people who use and inject drugs is only available in about 16 to 18 states out of the 36 states in Nigeria, which is inadequate to ensure that the 10-10 targets are achieved. Integration of PWID-friendly, gender-sensitive HIV services into public health facilities by states. We will need to move away from having donor-funded services at one-stop shops, at specific health centers, to a point where it is integrated into public health facilities at all levels, primary, secondary, and tertiary, and across all states. And we need increased state funding of HIV programs for people who use drugs. We can't depend on donor funding forever. Next slide. All right, thank you very much. Thank you. Thank you for the opportunity.
Thank you so much, Aniti. It's really fantastic to have you here to share the perspective from on the ground in Nigeria, and really appreciate your call to action as well from the community. So thank you very much for your intervention and for being here. So just want to pass along to our one final speaker to talk to today. from our other member state co-sponsor, Australia, Angela Wellbank, who's the Assistant Secretary from the Alcohol, Tobacco, and Other Drugs branch, like I said, from Australia. So Angela, whenever you're ready, please go ahead and take it away to close us off.
Wonderful. Thank you, Chair. The global AIDS epidemic remains an important issue for Australia and will continue to actively contribute to the response, including taking steps towards achieving target 3.3 of the Sustainable Development Goals, which seeks to end the AIDS epidemic by 2030. While the 2019 ministerial declaration noted with concern that the rate of transmission of HIV associated with drugs remained high, it committed member states to ensuring that no one affected by the drug situation was left behind. We acknowledge the impact COVID-19 has had on the implementation of joint commitments to address and counter all aspects of the world drug situation, and remain aware that those who are affected by the world drug situation, particularly key populations, are being disproportionately affected by the pandemic. As part of the COVID-19 health response, and in efforts to mitigate the pandemic's drug-related consequences, member states should continue to be mindful of these key populations. In 2021, Australia proudly worked with Namibia to co-facilitate the political declaration on HIV/AIDS at the UN General Assembly high-level meeting on HIV/AIDS. The declaration was ambitious, putting human rights, science, and addressing inequalities at the centre of the HIV response, and includes member states' commitments to put the global response back on track. As part of this political declaration, member states committed to urgent and transformative action, including to end the inequalities, restrictive and discriminatory laws, stigma, and multiple and intersecting forms of discrimination that perpetuate the global AIDS epidemic. Australia was particularly encouraged by the inclusion and retention of text highlighting specific concerns with the low global uptake of harm reduction programs and the persistent stigma towards discrimination against and marginalisation of people who use and inject drugs. Australia also welcomed the declaration's strong emphasis on people who inject drugs as a key population, requiring tailored HIV prevention approaches, and commitment to prioritising accessible, appropriate, person-centred services that meet diverse and multifaceted needs. Domestically, Australia's 8th National HIV Strategy sets the direction for Australia's continuing response to HIV and identifies people who inject drugs as a priority population. Similarly, Australia's National Drug Strategy also promotes reducing risk-taking behaviours through public policy and programs to reduce harm. Both strategies champion harm reduction approaches to addressing drug use and preventing the transmission of HIV, including through the implementation of needle and syringe programs, alcohol and other drug treatment and support programs, and measures to address social determinants of health. Central to harm reduction measures and approaches should be the involvement of people living with HIV and those that inject and use drugs to ensure policies and programs are appropriately tailored and community-driven. The 2016 UN GASS outcome document specifically reaffirmed the need to strengthen cooperation between UNODC and other UN entities when implementing the drug control treaties, and intensify the meaningful participation of and support and training for civil society organisations and entities. Internationally, more still needs to be done to facilitate this involvement if progress is to be sustained and ambitious global targets are to be achieved. We welcome and embrace the opportunities for stronger collaboration with civil society, particularly peer and community-led organisations, to drive evidence-based debate and multi-sectorial action forward at CND 65 and beyond, and through the broader UN system. As Australia reaffirms its commitment to the International Drug Control Conventions and to accelerating action towards the attainment of the Sustainable Development Goals, we also commit to supporting and advocating for the rights of key populations to be involved in the development and implementation of policies and programs that affect their communities. Thank you, Chair.
Thank you so much for being here, Angela, and really fantastic to hear from Australia, who has been such a good example of a leader of a member state during the high-level meeting last year and the global AIDS strategy. And thank you just for standing strong on key populations and human rights for people who use drugs. Very much appreciate you having here for the intervention. So that just about does it for our side event today, everyone. I want to apologize that we didn't have time to get through questions. I want to thank everyone for sticking around to hear all of our speakers. Like I mentioned before, the recording of this side event will be available online shortly, hopefully today. And we will send it along with the presentations from all speakers to everyone who attended for review, and so anyone can see anything else that they may have missed. So once again, thank you all for being here. We hope to continue this conversation with you all week in different side events and online. And I hope everyone has a fruitful day and a good CND. And also just one more thing, a special thanks again to Galina for being here and so bravely talking about the experience on the ground in Ukraine. Really, really fantastic to have you here. So just wanted to say thank you. Thank you, Galina. Great. Well, we will.
Thank you so much.
Yep, absolutely. Thank you all. Have a great rest of your day.